Okay, let's get started with this week's Miami Global Brain Tumor Symposium. We have a very exciting week with a guest speaker and panelists. Once again, just some introductions and brief intro for the rest of everybody. My name is Michael Ivan. I'm one of the brain tumor and skull-based specialists here at the University of Miami and director of research. And I'm joined by Jacques Marcos, who's a professor and co-chairman at the University of Miami and director of the cerebrovascular and skull-based program. Also Ricardo Comatar, who's the program director of our residency program, professor and director of our brain tumor and surgery oncology program, and Carolina Benjamin, who's one of our assistant professors and brain tumor skull-based specialists. Each week, we put on the symposium. This is now, I believe it's number 12. It's been going on since mid-April. We've had over 4,000 people involved with watching, and we can't do this without our administrators. They've been doing such an amazing job. Christina, Ingrid, Roberto, and Ignacio. Thank you again so much for doing everything behind the scenes, the illustrations, emails, and helping us with social media. If you want to know more about our symposiums, you can always check us out on Twitter at Neurosurgery. All the lectures are recorded and posted on our YouTube channel at University of Miami Neurosurgery, or you could go to our website at newjersey.med@miami.edu and look for the symposiums in order to register for this one and all the other symposiums that we offer. A quick shout out, on Wednesdays we have our brain tumor symposiums, and on Thursdays at the same time, same format, we have the cerebrovascular and skull-based symposium. So tomorrow, Dr. Morcos will be leading the way with Dr. Lanzino and Dr. Murrah about paraclinoid aneurysm management in a debate format. So be sure to tune in tomorrow at 5 for that symposium with multiple panelists, including Dr. Kadal Cohen, Dr. Amir, and Dr. Stark, Dr. Welch. Also, a quick teaser for next week on our symposium, we'll be welcoming Dr. Fernandez Miranda, talking about endoscopic surgery for chordomas. So be sure to tune in same time next Wednesday. So let's get to this week. So we have a great group of panelists. First, Dr. Rahman, who's joining us from the northern state of Florida, from the University of Florida. She's an assistant professor and part of the brain tumor center there. She's a brain tumor expert and also immunotherapy expert and a fantastic surgeon and scientist involved with glioblastoma. We have Dr. Raj Mukherjee coming from Johns Hopkins University. He's director of neurosurgical oncology at the Bayview Medical Center there. Dr. Zachariah, assistant professor at Penn State and co-director of neuro-oncology and skull base. And also filling in for Dr. Evans, who couldn't make it tonight, is one of our brain tumor fellows, Dr. Eichberg here from the University of Miami. So thank you, Dr. Eichberg. This week, we have a phenomenal guest speaker. I'm so excited that he was able to join us this week, Dr. Q. He's really a great friend, a mentor, and an inspiration to me ever since I was a resident at UCSF. We share that common bond in both being able to train in San Francisco, and he's really been fantastic to know and to watch over the years. He's a world-renowned neurosurgeon, scientist, teacher, and motivator, and he's also the chair of neurosurgery at the Mayo Clinic Jacksonville, a professor of neurosurgery and the director of the Neurosurgery Brain Tumor Stem Cell Lab. He's co-founder and president of the Mission Brain Foundation, which bridges resources in advancing international neurosurgery for teaching neurosurgeons all around the world. We could really literally have a 3-day seminar just about Dr. Q, his life, his basic science, and his research, but we only have him for a short period of time. So if you want to learn more, here are some of the books that he is either in or written. You can learn about his life and his autobiography, Becoming Dr. Q, or you could wait for the movie that should be coming out shortly. If you want to learn about his research, you could read one of his hundreds of research papers that are in many high-end journals. And if you want to learn about some of the operative techniques that we're going to be talking about today or other ones that he uses, you could look at Schminnick and Sweet, which he's the editor-in-chief and been so for many years, which is fantastic, or one of his many other books. So Dr. Q, thank you so much for taking the time to join us tonight and teach us all about awake surgery for brain tumors and epilepsy and really educate the world.
Well, thank you, Mike, and thank you, Jack, and thanks everybody, and also your coordinators. I feel like I am at home. So many Latin last names. Jack was teasing me right now because we have 198 people logged in right now, and we estimated that 190 are my family members. So, but what a great honor to be here with this panel. So I thought that you know, we spend, I don't know, maybe about 30 minutes or so, so that way we give time for the people that have some cases. I noticed that you put a tremendous lineup of cases that are going to be presented. Tell you a little bit of a short story of some of the work, and I wish I can tell you that is my work, but the reality is that the work that is being done by outstanding young people, and as you can see, some of the names down there, Karim, Gaetano, Diogo, they're really the people who deserve the credit for accumulating the data, putting these presentations together, and giving us an opportunity to learn from them as well. These are young, inquisitive minds like all of you that allow us to keep learning. And I am being very honored to be able to do so. So we'll tell you this little story as we go along. You know, one of the things that, just as a form of a disclosure, I wish I can tell you that I had more than that, but that's the disclosure. That's a, you know, we do have a sort of intellectual property on this one little device that we're gonna be seeing some data about. And I think it's important to be fully transparent because that tells you that I am biased towards this device, nothing else. I believe that it has some utility, but I'm also biased by the fact that we created this invention, Karim, Bill Tatum, who's an epileptologist, and myself. So you'll hear a little bit more about this. So two quick objectives for this talk. So I hope that I can keep you guys entertained and engaged. And I know that you guys have live questions, and Mike, if you can help me answer them as we go along, Miriam, anybody, or we can save them at the end, or a combination of both, we can go along this. I like to tell you a little bit about the role of awake craniotomies for tumors that are located in eloquent brain areas or near eloquent. And now we're beginning to understand that the majority of the brain is actually eloquent, you know, and it's very, very important because there are connections that go through parts of the brain that we used to think that were not as potentially important. But as we look at patients' quality of life, we define that indeed they are important. And then I'll tell you a little bit about the role of this awake craniotomy resections, especially when we want to go beyond just taking the tumor, but also take epileptogenic foci that potentially gives patients poor outcomes. And I think that that's something that we need to consider. So what about this awake craniotomy? What the background? I think all of us here, certainly the panelists, certainly you guys there in Miami, they're very proficient and do these surgeries awake. We have a tremendous multidisciplinary team in a lot of our centers. Miami does a beautiful job in some of these. I read some of your work, I follow some of your work. But we know that when we look at the overall age-adjusted incidence rates for gliomas, they range. It's not a tremendously common disease for us in major academic healthcare centers. We get to see a lot of them, and the reason why they are so important for us is because we have so few therapies that we can do. Surgery still being extraordinarily important. The seizures that happen, it just happens that a lot of our patients, they presented with either a bad headache or a major seizure, and a lot of them ended up developing epilepsy over time. 40 to 70% of those cases, when we look at the literature, some of them papers that many of us have been part of. Resection is important, even though it's never been proven prospectively in class 1 data. We know that to the best of our knowledge, how much we can take out of a tumor will have a potential positive or negative, if we can take it out, effect on progression-free survival and overall survival of patients. They tend to be in parts of the brain that are eloquent. And when we get to those parts of the brain, it's always a struggle to try to decide how much should we take out, how much should we leave, what is the balance. We take more, the patient wakes up unable to move, talk, see, whatever the consequence is. And that's why over the years, I began to do more and more of these patients awake, as you'll see. These are some of the papers. Right before I left Johns Hopkins in 2016, I went back and I put a lot of this data together, try to understand in my own hands how was the surgery not only being done, but the lessons, the pearls that I have, learned over the years. As Mike said, we train at an amazing place, UCSF, with Dr. Berger, had a lot of experience in awake craniotomies, and we got to learn some of those arts. But as we go along, and I'm sure Mike is the same way, you tend to begin to evolve and begin to create your own style. So I went on and I looked, into my own data, the volumetric analysis, central resection, in this case for insular gliomas, whether we're low grades or high grades. And there was no question that when we look volumetrically, the more that we can take out, whether there are low grades or high grade gliomas, it does play a role even in these more challenging gliomas like the insular gliomas. And you can actually see as well the progression-free survival. So clearly there is a role that extended recession continues to play. And this has been done, in several series around the world. For me, it was particularly important to look at my own data to see how that evolution happened over the years. I asked the question myself, what happens, if I looked at my own sort of progression from 2005 to 2009, into 2010, I did a lot of these craniotomies with the patient asleep, and I would just map. Why? Because I reserved the awake only when I wanted to test speech. And I remember in 2009, there was one of my residents at the time was my fellow Sean Raza, asked me, why don't you just keep everybody awake? I mean, even at places like MD Anderson and other places, people are doing a lot of awake craniotomy for motor mapping. And I said, why not? So I began to really, and I realized that my level of anxiety was just so much better when I knew exactly what I was doing, especially if you accumulate a relationship with the neurophysiologist, with the epileptologist in the operating room, with the neuroanesthesiologist. I began to realize that we could actually do a very good resection. So I compare, from 2005 to 2010, all the patients that I had done asleep, which was the ones that I had done awake, and I began to learn, and I matched some of these studies, and I asked the question to be able to have a very tight patient population as to what was the percent of resection in patients. Did it make a difference? How many, could I get more tumor, yes or no? And ask all these kinds of questions. And what I began to learn is that at least in my hands, those patients that were awake, they tended to do a little bit better in regards to not only the symptoms, but also potentially even in my hands, the actual, the length of hospital stay. And those are some of the things that we began to look into my own data. So I continue to ask, my own, my own questions is when I look at the expenses, because sometimes to be able to do this, we may have the preconceived notion that those patients could potentially either stay longer in the hospital or take longer in the operating room. Certainly, our experience sometimes can be that these patients can take a little bit longer. But I think that it was a partnership with the neuroanesthesiologists and the teams and nurses that really, over the years, allow me to make these cases a little bit more expeditious in and out of the OR, knowing that the patients get tired after being awake, so we have a limited amount of good time to be able to map. So this is also looking into quality of life. As you can see, those patients, seem to have a better quality of life. Part of it is as we're beginning to understand the issue of anesthesia can have potential side effects on a patient's outcomes, all the way from how they feel to memory to potential, being under anesthesia for a longer period of time in the post-anesthesia care unit and their hospital stay, as you can see, then at least in my hands to be shorter with the patients that I did awake. So we asked this. The thing that I was still not convinced about, and then we began to really explore, is that many times I wasn't sure if when I was doing the surgery with the patient awake, if when I had a deficit, is it because I was injuring something or because I indeed took a part of a neuronal circuit or a corticospinal tract that was important. So I began to think, what if these patients are having subclinical seizures and I don't even realize? Or I asked myself the question, I can potentially do a relatively good resection of the tumoral area, but maybe I'm leaving part of the cortical mantle that it is actually crucial for epilepsy in these patients, and I'm not giving them a good service. So by the time we came here to the Mayo Clinic, one day I was in the OR with Karim and Bill, and I told them, I hate these little strips when I had the crown, know, that we use to look at the after discharges. I wish there was something that I can just lay down there, like something round, circular, and then they drew something. And then like a week later, Bill came up with this model that he has a company to build for us. And since then, we have been able to collect some data. We looked, you know, at a match pair analysis in regards to the actual, you know, circular grid versus the strip grid. We looked at to try to understand, you know, we looked at these patients that we were monitoring, because at the beginning, not all the time I was using the circular grid. I needed to be convinced that it was indeed a better utilization of my time, because now we're talking about doing surgery for the tumor, for the cancer in this case, in addition to doing surgery for part of the brain that may be epileptogenic. And the question is, can I take it out safe? Extend the resection. And this is where I notice, and you'll see some of the work in this concept of supramaximal or supramarginal resection, and do it in a safe way. So with the patients awake, we began to understand this concept, and then we began to ask ourselves that question. So you'll see a couple of case illustrations where we use this technology. I'll show you some pictures. So we got to publish a few papers. And let me see, there's no sound right here, Ricardo or Mike, but let's see if you can see this video, right? Let me know if you can see it. So this is a 26-year-old patient, and you can see the preoperative MRI with the T2 flare. You're gonna see the lesion right there near very, what I would consider eloquent areas, dominant hemisphere. She's right-handed. We're doing the approach right here. We're gonna do the craniotomy. I prepared just the case with a moderately sized craniotomy. You're gonna see the injection. And are you seeing that okay, Mike? Is that
yeah, that looks great. Everything's going well. Thanks.
Right, so far, and there's no sound, so that's good. So we inject the local right there, right in each side of the arteries, and then we're just gonna open the dura. You'll see nothing new that you guys haven't done or seen before. And at one point, you're gonna see a little bit of the pale area. You can see it right there, the light reflecting. Then I need to understand, where is the eloquence? Am I going to find the mouth? Am I gonna find Broca's? So you'll see me stimulating, recording to make sure that all these are high density electrodes. That's the patient talking, reading, moving. That's the mouth motor. Then at one point, we're gonna find Broca's. You can see what maybe one gyrus away is going to be a little bit more pale. So now I know where I need to go, where I need to be. We begin the resection. You'll see the resection is gonna happen. We're gonna give the patient, so no issues. She went home in 2 days. It was as you can see, the pathology right there. So you can see the resection. I thought it was a decent resection, maybe a little bit posterior of T2 flare, you know, but no issues. 3 months later, you know, they called me. She was in Oregon, and they said, hey, this tumor is growing again. I'm like, that's impossible. And sure enough, I thought I had left a little bit in the back, but it was in the front this time, and she was having seizures nonstop. So I take her to the OR, we stimulate, and you can see right there, every time I touch that area, she's got these seizures, and all the symptoms. She was having some nausea, vomiting, speech, things like that. So we discovered that this whole area not only was different, but it was, as you can see, the pathology pretty soon, but it was a highly epileptogenic area. So we did another resection, clean it up nicely, we closed, we got out of there, and the patient did well, went home a few days, same deal. The pathology was an anaplastic astrocytoma, this time a grade 3. So if you remember, the first time, you know, this was the actual tumor. You're gonna see right there the area of enhancement. And the last time that we had done, that was a lower pathology. So indeed, there was a increment on the pathology. This was the first surgery, and what we found, and I'm gonna take you, and you can see the resection, and we knew that the pathology that we had gotten the first time, according to this, we didn't put it, but it was a low-grade glioma. So this time comes back as a grade 3, grew pretty fast, which is very unusual, epileptogenic 3 months later. So we ended up taking the tumor out. And that was how we ended up getting a little bit more used to trying to do the surgery through this device for the tumor as well as the resection. You know, we know that this epilepsy is common in these patients. We looked at some of the numbers, but it had been challenging for me to understand what parts of the brain are epileptogenic and what parts of the brain are tumorigenic and what parts of the brain are potentially both of them. And can you do a resection that goes beyond the borders? And as some of you guys have written, and you'll see once again, one of the papers that I cite from your work, supramarginal, supramaximal. So we did, this is the second case that I'll show. We have two cases to show. This is a 25-year-old hairdresser, seizures since she was 5 years old. She underwent a surgery for a left temporal ganglioma in 1999. And this last year when I saw her, she was having more and more seizures, lasting longer and longer. And they knew that this area was in the left side, potentially highly epileptogenic. So you can see right here, the axial flare you're about to see in the left side right here. You're about to see some changes, but really not that clear. And then here is the contrast, alrighty? And you'll see in the left temporal lobe, not really that impressive, but the EEG showed that there was a lot of seizures coming out of that region. And the epileptologist had been working with her for quite some time. So that was the actual first scan, and we knew that this tumor was coming in. So we took her, we used a slightly different area. You can see the areas that we discovered. We found Broca's dominant hemisphere. This is after everything is mapped right there. We have this grid that it allows us to operate in between. High density skull because the electrodes are very close to each other. And you can see 1 and 2 are after discharges. Every time I touch that area, we would actually activate area 16, 8 that you can actually see in the grid 24. So I knew that motor speech in Broca's was right here, this the Sylvian fissure. So I said, I got to give this patient a complete total lobectomy that is going to go beyond. The area of encephalomalacia was way out here. There was no eloquent function that I can find for a speech right here, but yes, for the after discharges. Normally, without this, I think I would have probably just taken, about 4 or 5 centimeters of the temporal lobe. In this case, we ventured more into the 7 to 8, but I had to confirm there was no function. And you'll see right now, or I kept her awake, of course, and I said, can I resect the anterior portion first, find out if this after discharges get better as I'm doing the resection. So that's another piece of information that allows us. So we went on and did this right here. You can see the resection. Was that a video? Yeah, it was a video. Let me see if I can play it. I'm not sure why it didn't play. I'm gonna try to see if we could. Oh, there you go. Okay, here we go. It's gonna play it right now. So that's the resection. So I try to preserve those after discharges. I am coming in anteriorly, and you can see preserve Broca's above, and we are going to do a temporal lobectomy. Try to resect as much as possible, but at the same time being respectful. In these cases, my biggest concern is that I get into the middle cerebral artery. They tends to be a little bit more inferior, not normal as compared to when we do the first surgery. This is, now we move into the microscope, and I continue all this area of encephalomalacia. We're working under the microscope. I'm just trying to make sure that I give this patient a good resection. Sometimes they get a little bit tender, inferior, so I have to be very tender because I have no way of injecting that area. So here we are. I found the temporal tip of the temporal horn of the lateral ventricles as the middle cranial fossa, the floor of the temporal fossa. The lateral ventricle is right there. The middle cerebral is, of course, to the right of the screen. And then I am doing the post-operative recordings to see whether or not you can see the big resection that I had done, a supramarginal. There were no after discharges. I stimulate, and to the best of my knowledge, there was no after discharges. So this is the resection right here. You can see the post-operative scan. You can see the resection right here. You can see the contrast, but there was no contrast before that. Nothing really abnormal, nothing new. But in this case, we were able to take this patient out. These are the challenges. It turns out to be a low-grade tumor, some remnants. A lot of it was also encephalomalacia. A lot of it was dysplastic tissue. But the issue, as we know, with these patients, as many times it's impossible to tell what is tumor and what may be infiltrative normal brain, and to separate. And you want to give these patients a nice resection to cure them, not only potentially to control their disease, their cancer, and control their epilepsy. But the challenge that we have is that these cells are very invasive. They go all over the place. So this is work from our laboratory. This is what we call an organotypic. This is where we have human cells migrating in human tissue. This is actually a paper that we are finishing. We've been working on this paper since 2003, Mike. I got my first image when I was a postdoctoral fellow at UCSF. And this is probably the longest paper that is taking me time to collect all the data, and you can recognize, because back then, we actually had to do work in the laboratory, and I got a grant to work with Arturo, and I remember I tried to do the first experiment. So it's taking this long, but for the first time, you can see human cells migrating in human brain. This is a piece of brain that we keep in a microscope. We keep it alive for up to 2 weeks. We can put cells that are marked with GFP, but this is the challenge, that they're very active. They migrate, they invade, they alter probably the circuits, the neurons. They do a lot of stuff to the human brain, but now we're beginning to break the code. We have used a little bit of technology. This is one particular technology that I mentioned. Is called the optical coherence tomography. We were very blessed that Carmen, who was a graduate student in our lab, she worked with Shinde Lee, who's a physicist, by the way, is a PhD, and myself, and brought us together. And here I am. This was 2015, right? Maybe a month before Kai Sun-Chai-Chana finished his residency at Johns Hopkins. He's now here with us leading the brain tumor program. We are doing this case together and collecting data. And you can see with this device, we can mark the cancer, not cancer. Since then, we have a few more papers that we published. We have a prospective paper that we're doing, that we have collected about 25 patients in the operating room. Good technology. For me, it was important that I love what we do in the intraoperative MRI, but we all know that it is challenging sometimes to use. The quality of the image is not great. The operating room with an MRI can cost anywhere between $5 to $7 million. So this device that you are seeing right there with Shinde and our team, we can build a home system, for about 50 to 60 grand, because it's really put from all different parts. And so we ended up also putting IP on this intellectual property, not only in the actual device, the optical coherence tomography, but also the software and the artificial intelligence to be able to read what is red and what is green. So this is us operating, collecting data. We ended up publishing a paper, the first paper in Science Translational Medicine. Since then, we have gotten 2 other papers, one in Science Advances and one in Clinical Cancer Research. I think our team put another one right there, but you can see Sean, Kai working. They're now faculty in our group, and they are faculty that continue to push some of the things where we have limitations. So we ended up doing this this work in an attempt to try to understand how can we look at these cells migrating. This is us collecting some of this data. You can see the cells moving up and down, right to left. Those are what the colors mean, because we just couldn't crack the code. The challenge that we have had in the laboratory when we see the cells migrating is that most of the images that we do are 2D, but the cells are moving in 4 dimensions. So this is a software that an engineer at the NIH invented to be able for us to quantify this migratory movement. Without this, all you see is cells moving side to side, and really difficult to understand. But for us, it's important to understand how they move and to see them move in the operating room potentially, or to see them invade, or to differentiate normal from abnormal, allows us to do even more resection. This is getting into the realm of the supramarginal. So this is where the latest paper where we use artificial intelligence for the detection of this infiltration using computational models. This is actually, with Shinde and I, we partner with a scientist that is at Rice University, and they use a lot of artificial intelligence. So the last few minutes, I'll tell you a little bit about this, but of course, I'm gonna end up the next 5 minutes. Gaetano just pointed to me the time, so I want to be respectful of everybody's time, is that it's great that we have awake craniotomies. It's great that we can detect oncology as well as epilepsy and try to do better for our patients. but can we do without it? Can we just resect, what is called the influence of maximum safe resection of glioblastoma? This was actually a paper that Dr. Sawaya published not long ago in Journal of Neurosurgery 2016. We did a small paper into the role of gross total resection. How much should we really try to do? This is actually a paper where Miriam was also collaborating. Since then, I also, with Dr. Rahman, I've been able to publish some of these papers. You can actually see her right here working with our team, obviously. So the reality is that a lot of this data is very, very important. And you can see from your own group, Mike, I saw your paper that you guys just published, and I cannot take credit, but that was these two guys right here who keep looking at the literature. So we put that paper because I think it's a very important paper that deals with this issue of supramarginal, supramaximal resection. And I think that is becoming clear to us that this is going to be something that we should attempt. Not every patient, of course, is going to qualify, but if when possible, it's clear to us that the more we can go beyond the contrast is going to be important. So this is Tito and Ricardo, who are another two of our fellows. They look at our data. They review almost 1,000 cases. And out of those, 888 appear to be good candidates, but I said it's too much heterogeneity. Can we limit to potentially the IDH wild type? From that, they came up with 101 cases. And then we asked the very simple question. The question was, these are patients where the whole area of contrast enhancement was taken out, and then they had to go beyond that area of contrast. And that's why we ended up coming only with 101. I say, let's get out of the equation the contrast. Let's assume that it is a given all the papers that have been published over the last 5 years or so. I want to know if when you go beyond that, does it make a difference? And can we make it in one patient population that is more homogeneous, in this case, the IDH wild type? And that's when they come up with 101 cases. And that's the methodology. You can see they measure everything. These guys are very bright, and they just spend hours and hours. They're non-biased. They look at their data. They try to make sure that there is reliability and there's not a lot of differences. They ask each other, both Tito and Ricardo, when they measure the volumetrics, to make sure that they were reliable and then the measurements were according to what the criteria that we had. You can actually see right there in green is the tumor, and then right here in blue is the tumor, the contrast enhancing, and then they subtracted those who were cystic. Then they look at around the area, all the area of the tumor, and then they only look at the area that has flare. In this case, we use T2 flare as the surrogate. We know that a lot of this can be tumor. We can tell at which point is the density of the cancer is going to be potentially working against us. If we take it, maybe we take areas of the brain that are functional. This is where it gets dangerous. So when they look at the multivariate analysis, the first thing that came very evident in this patient population is that once you get rid of the contrast, if you only look at this area right here, the flare, once they look at that, they realize, wow, it seems to be that a minimum of 20% of that area makes a difference. And beyond 50%, we really couldn't see a difference. We suspect that there's a difference. We just don't have enough of a power to be able to look at that. But there is a point where, as I said before, you get to areas where the density of the cancer may not be as intense, and you are getting into eloquent corticospinal tract or other functions that may work against you. And Miriam and I have a paper that she did a beautiful job in which she asked that question. If you give a patient a deficit, what happens? And we negate the potential benefit effects of a super good resection, obviously. So they ask all these questions, and these are some of the data that I end up with. Patients that have less than 20%. So they ask a binary question, less than 20, more than 20. Boom, positive. They went all the way up to 50, 20, 30, 40, definitely. Less than or more than. Once they got to 50, there still was a difference. Once they asked the binary question of 60 or less than 60, more than 60 or less than 60, that's where we really didn't have much of power although we suspect, like I said, there's a potential benefit, but illustrating that a marginal we call the margin of the contrast. Supramarginal is important. Supramaximal maybe to us means that you go beyond the maximum that you can resect and you go into parts of the brain that you don't see any T2 or flare changes, but we know that this cancer has to be there. Small cells, because we understand that they continue to migrate, we just don't detect them. So from there, you know, we came up with this idea that indeed in our hands it's going to be important to try to go beyond the margin when possible. We keep the patients awake, we resect the tumor, we resect potentially areas of the brain that are epileptogenic, and we like to think that we are helping the patient. So this is our conclusion. 20% was the minimum that appears to be important, and 50% was the maximum. Beyond that, we couldn't see a difference. There was no negative effect either in regards to the actual outcomes, but nonetheless, we have to be very cautious in what we say. So I wrap it up right there, just give you some food for thoughts as we see some of the other cases that are going to be presented by our colleagues. In our hands, definitely extended resection is correlated with increased overall survival and progression-free survival. Awake craniotomy is a tool that can be used in some cases to achieve a higher extent of resection with preservation of function. For me, it's been crucial to make sure that I have a good partnership with people in neuroanesthesia, neuromonitoring, epilepsy folks, neurology, as well as neurocritical care. You know, a very large percent of patients does present with brain tumor related epilepsy. And for us, it's important to try to help them as much as possible. In intraoperative localization of the foci of epilepsy can potentially lead to a faster recovery and better outcome. This is all class 2, class 3 data. It's not class 1 data. I think it's going to be very challenging to do these experiments for class 1 randomized trial, but I think the data seems to be supporting a safe extent of resection. So I leave it at that right there, Mike. I wanted to make sure that we give some time for our colleagues. You know, I wanted to give some food for thought.
Yeah, no, that was fantastic and very timely to, I think, everything that is going through most neurosurgeon, brain tumor neurosurgeons' minds at the moment. So thank you so much for that. We just have a few questions before we get to the panelists. So I'll just answer the ones from the audience first. Dr. Bowser from University of Pittsburgh asked about the ring electrode. It says, are you recording from the ring electrode bipolar contact to contact or contact reference to scalp electrode?
It's contact to contact. Very good question. That's contact to contact. We don't have to put a reference to scalp electrodes, contact to contact. So we are very, very localized right there.
And my question on top of that is, are you using the ring electrode to look and prevent intraoperative seizures, or more to look at the discharges to prevent and resect seizure foci around the tumor?
Mike, we can use both because we can use it. So nowadays, for instance, when I'm doing surgery and suddenly the patient has a deficit, and I pause, the neuropsychologist tells me, Dr. Sapsi, who's a neuropsychologist, says, hey, hold on one second. And then sometimes the neurologist goes, oh, I see activity in X, Y, and Z. And so I know that I am potentially, the patient is having a subclinical seizure that is affecting their function. So that allows me to understand that. And sometimes I will be able to see areas, the patient keeps talking, moving, doing everything, and I see an area that is going like this, that is having an epilepsy, and the patient is totally fine, and is outside of what we would consider contrast enhancing. And sometimes, like, it would be outside even of the area of flare, but I know it's safe. I know the patient is having no deficits. That area is going like this. I resect it. I do what you guys describe as a supramaximal. So I go beyond even the margin of the T2 flare, and I tend to resect. So that's how I'm gaining that information live intraoperatively. So for both.
And are you seeing, as you obviously at the beginning is when you always get the best EEG data for understanding where the discharges are, but are you able to continue to use it throughout the resection to kind of look as you interrupt the brain and you kind of have, it's a little bit less reliable at the end of the resection, but you're still able to get some recordings?
Yes, you're stable. And I think that where I'm limited there, and I challenge our youth and our thinkers here in the audience, what I'm still, I don't know if you noticed, it's still plastic, you know, like It's not plastic that completely sticks to the brain nicely, so it can have a little lift. So sometimes the contact is not great, so I have to put a cotton ball or something to make sure that I have good contact with the brain. The material is okay. It's definitely than putting the crown, and it's definitely than putting the strip electrodes that are not high density, but it's still not ideal. I actually have, the team is working in potentially biomaterials that, first of all, they're wireless, so I don't have to, the wire itself, by the way, that sometimes can be so rigid that the electrode is not contacting very well at that level of 1 to about 26. So what I'm trying to come up with the design with them, with our students, that is just completely just sits down in the brain and is wireless. So that's the next generation. I think that that's going to help us tremendously, you know, to be able to do that.
One other question from the audience, Dr. Maldonado asked about in the temporal lobe patient you showed, did you monitor seizure activity at the mesial structures as well as the lateral cortex, or when do you decide that?
In that particular case, I did not, but every now and then I do put those high density, small little depth electrodes, you know, to be able to monitor that. In that particular case, I did not, but it's very common that I will monitor, you know, put distally to the area where I want to do surgery, something in the hippocampus, to be able to, as I'm doing the surgery, to see whether or not the patient is having some potential seizures. And then if it is, then I have to make the decision, do I do the so-called supramaximal, where I go to 6, 7 centimeters, 8 centimeters to do a very large resection, and that gets a little bit more tricky. But for me, keeping the patient awake makes it a little bit more tolerable, in the sense that at least I feel confident, to the best of my abilities, testing there with the neuropsychologist, I can make those decisions as I go along.
One more question from Marcelo Platis. What's your impression of using intraoperative MRI and awake craniotomy, and comparing and contrasting the two to get the maximal resection?
I got to tell you, I do love the intraoperative MRI, and we have it available. But if you ask me that I use it all the time, I will tell you, no, I'm not using it all the time. It's challenging. It adds about an hour minimum of time to your surgery. And sometimes, you know, what happens is that I already have given the patient a resection as comfortable as I am, and I'm beginning to get deficits. And I don't know if it's because the brain is shifted, or I have taken potentially some of the deep white matter tracks. So I get very nervous. So I think that as much as I love the technology, it's got more limitations than I like to acknowledge. But I do it because I think that we need to challenge ourselves to do it better and also more fiscally responsible. The reality is, you know, that one particular case that you saw, you know, I have had cases where I said, oh, I done a marginal supramaximal resection, I feel, and then suddenly there will be a little bit of T2 flare anteriorly, far away from the eloquence. So I said, all right, I can go in, even if the patient is no longer awake, I can take that with no reservation. So, but I can count those cases with one hand, to be honest with you. So we can do better, hopefully, with some of these devices that allow us to see penetration of cancer with much less, being much more fiscally responsible.
Yeah, and that's for me. One more question is you know, the idea of looking beyond and looking at the invasion margin. This idea of 60% resection of the flare, and using adjuvant therapy, adjuvant equipment like OCT. Do you think we're going to end up looking at important quantities of, like, what is the density of tumor and the tissue remaining? And that's going to become more important than perhaps the preoperative MRI, and that's going to lead us to better outcomes?
I think so, Michael. I think that that's what it is. Because we believe that once we get to 60%, what we suspect is going on is, once you go beyond, you and I know that the density of cancer is probably not the same in the periphery, but there is cancer there. There's cancer already probably in the other side of the brain, which is the MRI won't pick it up. But then I go back to, like, the paper that I did with Miriam, where we know that if you give the patient a deficit, that's going to negate your positive effects. So maybe in the future, we'll be able to get a sense as to what is the density in different regions of the brain of the cancer. So potentially you hit those areas with a little bit more radiation. So you get to map the brain for cancer density before you even leave the OR. That may help our future therapies that are become more personalized.
Great. So Dr. Rahman, if you want to load your slides first, and I'll open up to the rest of the panelists if anybody else has a questions for Dr. Q while we wait for
Yeah,
Miriam's.
Mike, can I ask a quick question?
Yeah, of course.
In Spanish.
Yeah, you're right. How about French or Arabic? Q, listen, early in your talk, you mentioned you compared your own series of awake versus asleep. Was that sequential cases or concurrent cases?
No, this was actually my very first 5 years when I used to do a lot of sleep, and then my next 5 years. And then one of the questions that I asked myself, Jack, was it because I got better over the second part of my career from 2000
Exactly.
to 2010, and then
Right.
2010 to 2020. So the first thing that happened is that my extended resection was very good when I did them asleep and when I did them awake. So there was no difference in regards to the extended resection. The difference for me in my own hands was in two: the length of operations, and that could have been influenced by my experience. The second, it was shorter when I kept them awake, but the length of hospital stay also was much shorter when I did them, awake in the patients. So that's what it is. But of course, I cannot rule out. So now I'm looking at my third, from 2015 to now and matching those cases. So now look at the third period of my life to ask myself that question.
Great. That's what I was driving at. And it's
Yeah.
interesting. Yeah. Thanks.
Thank you, champ. Good. Let's do it.
Okay.
Thanks for a great talk. And Mike and Jack, and Rick, who are online, thank you so much for the kind invitation. And so Q, I was actually just going to share a couple of my cases. One that I've already done surgery on, and another one actually that just came in today that I'm planning surgery for and wanted to get your opinion on. So I'm just going to advance. So this is a 55-year-old female who I actually treated about 3 years ago. Initially, she presented with a seizure. She was neurologically intact. This is her functional MRI, and she had just this very tiny left temporal lesion that was enhancing, and you can see the T2 sagittal. She had left dominant language, and so I ended up taking her to the operating room to resect this, and we're able to get a gross total resection. Of course, a small lesion. We're able to find both semantic function and word production during surgery. She had no problems. Her path at that time, this was 3 years ago, was an anaplastic astrocytoma, but it was IDH wild type. And so she went on to receive a STUP protocol, and then presented 2 years later with this, which is this new enhancement along the anterior portion of this cavity, and then this new T2 signal you can see on the flare. And one question before I tell you what I did was, how would you manage this?
Obviously, the first thing that happened, so this is new, the contrast
new.
a little, and the flare is new, going anteriorly also for what I see. But then you have that flare going into the atrium of the ventricle, it seems to me. So it's beginning to track, and that's what, we were alluding to in the prior talk, and Mike was asking about. That's potentially already cancer that is beginning to spread out, because I would imagine that this is outside of the radiation field, and it doesn't have the look or radiation side effects. This is 2 years later. So at this point, new symptoms, if I remember correctly, or no symptoms at this
So this
point.
was asymptomatic.
Asymptomatic. So just a new finding. 2 years later, I don't expect to see, unless, of course, there were already changes prior to this, but I'm going to work in the assumption these are new findings, that this much edema wasn't there, or this much flare wasn't there. You're probably getting scans every 3 to 6 months, depending. Every it's a little bit different. So I'm going to work on the assumption that none of this existed. There was a little bit of changes in T2 flares, but not like this. So to me, this is probably a recurrence. It's 2 years later, even though it was anaplastic, but it was wild type. So I think at this point, potentially, I would recommend another functional MRI, and I would probably, the patient is now 57, if I remember correctly, 2 years later. So I think that this is going to require you potentially either, going into the OR sooner rather than later, or getting a very close MRI. It's going to depend on the preference of the patient, how well the patient is doing. But my suspicion is that this patient is going to require another resection to reestablish diagnosis and give her a good cleanup. So that's the way I'm thinking about this. I'm not quite sure. Let's see what you ended up doing.
Yeah, so I agree with you, especially with the IDH wild type. I felt like this was probably tumor recurrence. I actually ended up taking her to do a biopsy and laser ablation just because I felt like it was small enough that I could do that. And so her path results actually came back as radiation treatment, CNS necrosis. But we were concerned enough about her imaging that post-lit, we put her on pembrolizumab. And so she was maintained on that and was doing pretty well. And then a year after that, she developed this enhancement along the original resection cavity and lit treatment area. What's interesting is that when we redid her fMRI, she now has, I don't know if you can appreciate this, but on the right side of her brain, she now has language function, which did not exist on her. She had a little bit of right-sided function on her initial functional MRI, but now this was much more robust compared to the initial time. So she's already or at least demonstrating some plasticity, and now had this much uglier looking enhancing lesion along the left temporal lobe. Honestly, neurologically still doing pretty well. Maybe some mild word finding problems, but was essentially asymptomatic from this. And so this time I actually did end up taking her for a resection of this. And we kept her awake. We mapped her. This is her post-op imaging. This is pre-contrast, post-contrast, and this is just some blood in the cavity. We were able to achieve a gross total resection. And right here is where we ended up finding kind of anomia on testing and trouble with complex commands when we mapped here. And in addition to doing what you talk about with the looking for after discharges, and I know you do this as well, what I found to be very useful is continuous subcortical mapping during the resection with basically a stimulating sucker, you know. And so my sucker basically has the stimulator built into it. And so, and I set that relatively high as I start off because I'd rather find that function for, you know, with some tissue in between. And then as I find something, whether it's language or motor, then I'll start turning the amplitude down so I can get closer and closer until I feel comfortable that I've removed as much tumor as I can, safely getting to that white matter tract. And so in her case, we found function on the surface, and more importantly, down deep here in towards the deep part of the resection cavity, found archaeofasciculus essentially through her trouble with naming. And we were able to preserve that. Interestingly, her path actually came back as identical to her initial path, but this time it was called the GBM because of the new WHO criteria. It was IDH wild type, TERT mutated, and so although it looked histologically just like it did the initial time, it now meets criteria for GBM.
Beautiful resection.
Oh, thank you.
Yeah, I think that's really interesting, Marianne, because you know, at the first recurrence, there was that big question of, you know, do you go after that enhancing component that's small and new, or do you target that flare that's going posteriorly? And so, you know, this is a great example of sometimes it's important just to target the most aggressive component of this mixed heterogeneous glioma and keep kind of pounding at the really, you know, the enhancing component of it with the hopes that the non-enhancing flare in the posterior part will stay calm for a period of time. And so I think it was a great job.
Yeah, really nice case. Just curious kind of with that, with the lit, you know, I've always kind of wondered this with these kind of peri-eloquent lesions with like kind of deciding for lit, right? You kind of lose the ability to map, and as accurate as, you know, estimating that ablation zone is, I always worry with the proximity to eloquent structures of rendering a deficit with the patient asleep and kind of losing that. So just kind of
that's actually a great point that you make, and I totally agree with you. There's no way to predict, even though they'll try to sell you, the lit companies try to sell you that you can predict the ablation zone. In my hands, at least, I don't feel like that's the case, and I feel like depending on the tissue type and its consistency, kind of, you know, ablates at different speeds and volumes. But the one I will say, she was actually she was like the perfect patient to do awake. And in general, we do our lit cases awake here. And the way we do that, now I will say the benefit to that is that, you know, it's less time, at least for us, it's less time for intra-procedural. They tend to leave faster, you know, they leave the next day after surgery and they recover nicely. But the challenge to that, what I found is, what we like to do, because we do it awake, is to get serial exams during the ablation. The limitation we have in doing that is that, unlike mapping, you're not actually mapping anything. So you're basically ablating and just hoping you haven't gotten to, the eloquent area, and then you can ablate some more. And then the biggest limitation to that for us is that we do not, the patient's not asleep under anesthesia, and we don't have their head immobilized with pins. They're immobilized with, we have this thermoplastic mask that we use to contour to their face, and we kind of tape their head down with a coil and things like that in the intraoperative MRI, but they're not actually immobilized. And so when you do serial exams, you have to be very careful their head doesn't move, because if it does, then you start all over. Like, it's not dangerous, but it just makes the procedure longer, because you have to get another anatomic MRI and restart. So that's been our limitation with it, but that's how with her lesion was small enough and anterior enough to where her prior fMRI had shown function that I felt comfortable doing it. But you're absolutely right, that is definitely a limitation.
And just the last follow-up question to this: do you surmise perhaps that there was a sampling issue as regards
absolutely
the recognition of just treatment effect, and in fact that was
absolutely. And actually, it's been such an issue with me. All these patients, you biopsy them, it shows treatment, like for GBM, right, or malignant glioma, you biopsy them, it shows treatment effect, and they all die of tumor in 6 months. And so, like, I feel like the biopsy showing treatment effect should not prevent us from changing therapy or being aggressive with these people. At least for malignant glioma. It's different for brain mets and other things, but for malignant glioma, I feel like you should just, as soon as you start to see these imaging findings, we should be aggressive and change treatment in some way.
Yeah, and I know that's something I think Mike and Rick have been proponents of too, of kind of biopsy oftentimes not adding much in those cases, and going ahead and treating regardless of the.
Absolutely. And that's why we kept her on, we changed her to Pembro as soon as, even despite the biopsy results.
Beautiful case.
Did you have another case, Miriam?
Yes, and I don't want to, I know there are other panelists who have cases, but this is actually, I don't have this guy's functional MRI scan done yet. It's supposed to get done tonight. But this is a 67-year-old who just arrived, who he's pretty high functioning usually, and he presents with falls, and he's had cognitive issues specifically with math, and also a little bit with language, with reading words or being able to write out his checks. He is ambidextrous, and he writes with his left hand. And this is his T2 scan here. And then this is his post-contrast scan that shows this patchy enhancement that wasn't there on his T1. And I wanted to get, everyone's kind of opinion on this case. I have a couple of my own thoughts on this, but I want to hear what Q and others had to say.
Any other past medical history, Miriam? Any?
He's totally healthy, never had a medical problem, has not had seizures, works as a contractor, and the main reason he presented was because he fell at home.
The only thing that I always get concerned about that, especially in the sagittal, when I look at something like that, I always get concerned. Oh, can this be something like a lymphoma? Everything else I know what we need to do is as far as trying to maximize the resection. But of course, when you get to the realm of the lymphomas, you may not necessarily be so aggressive. So the way that I normally manage this, I make sure everything is fine, there's nothing else, and then I proceeded. My biggest concern in this is in the deep corticospinal tracts, more than language and speech and vision. I don't worry too much. I bet you that he's got some deficits already, but it's the corticospinal tracts, that worries me that I may take. So this is where your soccer is important. I tend to still, even in this location, I tend to keep them awake. In this case, a left-sided. So of course I work in that side as well. And depending on where you are and how you position, you can be able to tilt the table. And then I start with the biopsy, send it to the pathologist. They give me a sense. If they say, oh, looks like a high-grade glioma, then I continue to try to move expeditiously, try to resect as much as possible. If they said, oh my God, it looks like a lymphoma, then I may back down right there. But I will always come in with the idea, we'll try to give the patient a resection as much as possible. Some people do a biopsy before, and then they plan accordingly. they get a corticospinal, they get a functional MRI with DTIs. You can also do that. It all depends, obviously, on your level of comfort and your, your partnership there with the radiologist, but those are the kind of things that I do for this type of cases. And, it also depends on the patient. Some patients are, oh my gosh, so biopsy first, and then we need to know what it is. So then you have an answer. If they said, I'm ready to, if you can take it out, let's take it out. Then it makes, your decision a little bit more expeditious. So that way you get to do everything in the operating room. I don't know if anybody else has any other ideas there.
Yeah, I would do pretty much the same thing. Actually, my case is almost identical to this.
Oh, really?
And,
well, maybe I can learn from your case then before I take this guy.
So, yeah, I would go in with the intent to resect, just like Dr. Q said, get that intraoperative histology to rule out, something like a lymphoma. Again, it looks more glial. I don't know, just maybe a gestalt, but yeah, and then exactly like you said, get the baseline functional and tractography data to get a sense of where the corticospinals are, where the SLF is. And then I think go in with the intent of resecting kind of all that, what looks like non-enhancing tumor in addition to this enhancing tumor. I'd also say that in these, I've found glial to be of benefit as well, especially with this kind of wispy enhancement at the margin of the resection, could be a nice adjunct as well.
Yeah, and I would just say, at this age group, you're expecting an IDH1 wild type, and so even though on the flare or the T2, it looks like it's going to be nice borders, it's probably not going to be as nice as you would expect. And the other thing is just that, the idea of what do you do with the corpus callosum if it's invaded, and I typically am pretty conservative if it gets down to the corpus callosum for this patient, and I would definitely stop before you got there.
Yeah. So thank you for your insights. My plan was to take him for resection. He felt that would be reasonable, and I agree, Q, that to send a frozen early. My concern with him is that he already has a hemisensory neglect and sensation loss, and what I'm mostly concerned about is I really think his primary somatosensory pathways are completely within the tumor, and I think that actually may be his biggest disability for him post-op, because even if you save cortical spinal tract, if you make his neglect worse and he loses proprioception on the right side, which I've seen once before, they still functionally can't walk or use that hand, and kind of the cognitive issues with it. So I feel confident that we'll be able to find cortical spinal tract and our deep white language pathways along the parieto-temporal junction. But my bigger concern is somatosensory. And I feel in my hands, when I have a tumor like this, where it's like centered over somatosensory, I feel like my mapping is not reliable, that I can't actually really map that track, because I feel like it's so my theory is that it's so infiltrated by tumor that it's not really that functional, and that's why I don't really do a good job of finding it. But I wanted to know if anybody else has had that experience as well.
One thing that I do sometimes, Mira, and I don't know, he's a contractor. So one thing that you can do with this case, and this is the psychology, we have a neuropsychologist, Dave Sapsovitz, that does all this, he evaluates the patients before and then during the surgery. Sometimes they like to do things, mechanics, some patients like to play the guitar, and they have a baseline function. So he has them doing all kinds of crazy things in the operating room that, to the best of our knowledge, allows us to see whether or not you begin to pick up a deficit as well. And nowadays, the devices that we use, even for sensation, for strength, they are electronic. So you can continuously track that over time. It's not easy, but it's, I think that this is, we're having a good neuropsychologist there with you that can help you, can give you at least to the best of your because you're right. And at the end of the day, there's no test that is going to be perfect, as you know. But those are the kind of tricks that we use for those type of cases.
Okay, since Braz is similar, why don't we go to his next and see what he did. Thanks so much, Miriam, for those cases. Those were great.
Thank you. Thank you for giving me the opportunity.
Sorry about that. Yeah, it's, again, Dr. Q, fantastic talk. I think really highlights so many of the key points of these awake cases and the benefits of it. So this is 32-year-old woman, just history of IBS and anxiety, otherwise very healthy, works as kind of in the healthcare field. Again, similarly, presented with several weeks of right hemisensory changes, very subtle, some subtle fine motor stuff with the right hand, and just not quite as sharp, kind of a little fallen off at work, but very subtle. Strongly left-handed, and she has her imaging is this. So again, this heterogeneously enhancing lesion, kind of the left parietal lobe. There's kind of a cortical area presents to the surface here that looks like kind of infiltrating a tumor, non-enhancing tumor, some flare signal change, and then kind of this patchy enhancement with this kind of cyst where the cyst cavity enhances. And so our functional MRIs aren't quite as pretty as yours, and they tend to look like a lot of blobs, but she was, despite being left-handed, was strongly dominant left side for language. And we were doing this really more just to localize language or lateralize language. And so to look at it, you can see finger tapping is kind of where we would expect it, just kind of anterolateral to the tumor cavity. I think this is where the tractography is particularly helpful. So the red arrows are the corticospinal tracts. Like Dr. Q was saying, I mean, the corticospinal tract is really just draped on the anterior surface of this cyst. And the superior longitudinal fascicula is represented by yellow, kind of just at the anterolateral aspect of that cyst. And again, you could kind of see that kind of going down, kind of draped over the anterolateral aspect of the cystic portion of this lesion. So I think this is one where, I think people look at this, might look at this as, this is a tumor that I think is not super uncommon. It's not one of those, this is the hardest tumor you'll ever see. And so I think, the way people look at doing this, I think is of interest, and kind of interested to hear everybody's thoughts on this, similar to Miriam's case where, are you going in with the intent of just doing a glorified biopsy, or are you going after this cystic component and that entire enhancing cyst capsule? Do you do this asleep with, again, the focus more on the corticospinals because of its posterior location and perhaps some difficulties positioning? So I think kind of those are the questions, right? So how much does the language come into play? Really no language dysfunction related to this. You have some of the subcortical language areas perhaps adjacent to it. Positioning issues with these posteriorly located lesions. A patient who maybe has some baseline anxiety, and how do you address that with these awakes? And some of the adjuncts that we talked about, neuronavigation helpful, and again, with an enhancing tumor, I think the Glealan is another adjunct, can be quite helpful. So the way I think about this, I think so much of it is the counseling with the patients, discussing beforehand, establishing a relationship with them, having them meet with the anesthesiologist, having them meet with the neurophysiologist or neuropsychologist. I think goes such a long way. I think it's that fear of the unknown that when you first say, hey, we're going to do this awake, can really kind of throw people off. But once they understand it, I think most people are kind of become invested in doing it. You're letting them know that they're helping themselves out and kind of helping you do the best job possible. And I think the additional comfort, like Dr. Q mentioned, of having the patient awake and talking with you and working with you really allows you to push the operation, I think, in a way that's difficult to do with the patient asleep, even with neuromonitoring. So positioning, again, just like you said, I think she happened to be young and thin and with a favorable kind of neck, but people are awake, you don't want them to be uncomfortable. So this is just a modified lateral position, kind of bumped up on her side, ensuring that her shoulder's comfortable, with the head turned gently, and using the bed. And putting yourself in a little bit, perhaps, of an uncomfortable position, sitting oftentimes so that you could look and see well, allows you to do that. So again, that's what we did. We did an initial sensory map to look and identify central sulcus, which was as expected. You push fairly anteriorly, and then stimulated directly over what was obvious tumor on the surface. And then resected down into it. When we got into the cyst, it was a nice anatomic landmark, knowing that kind of ventrally and laterally we're going to identify corticospinal tract and SLF, and we did that just while putting her through tasks throughout the operation. This was an IDH mutated 1p19q code-deleted anaplastic oligodendroglioma. be able to get a very nice resection, gross total resection, all the contrast enhancing portion of the tumor. And on a FLAIR image, got probably 90% of the FLAIR signal as well. We did kind of reach the corticospinal tracts and SLF on the kind of subcortical mapping. So worked out well. And now that it's the discussion regarding kind of adjuvant therapy for her. So kind of similar case to Miriam's and
Brad, one quick question. I think you formulated the question. So if you go back to the images, the pre-op, the cystic component seems to have a contrast. Keep going even more. That one right there. Yeah, the cystic component. You asked, did you go after the wall of the cyst or you just decompress the cyst?
I took the entire cyst wall. This is where I think the glial was really nice. I mean, it was obviously frank malignant glioma.
Gotcha.
With the glial, it was very robustly, pink fluorescent, and so I think that, in addition to the subcortical mapping, was very helpful. Allowed you to push it. I mean, doing the operation without taking the cyst was extraordinarily easy. The tumor was relatively obvious. We took it out, and then it was that cyst, and it's kind of following that floppy cyst wall. Once it's decompressed, becomes kind of the more challenging component. But yeah, we resected the entirety of the cyst wall here.
And that's what it gets challenged. If you don't have the patient awake, this is where people are afraid of taking the corticospinal tracts, in my opinion. That's what I was saying. I mean, to me, it's always, because I did it, with the patient asleep, and then they wake up, they're not moving, half of their body. And I'm like, oh my gosh, is it just because the brain is sagging or because I took the corticospinal tracts? And it was hit and miss. That's when I began to really keep them awake.
Yeah.
More comfortable for us to know, and definitely uncomfortable because you're operating like this. Sometimes I have to put a little, Greenberg just to hold the brain so it's not falling on you. Just
absolutely. And the other thing that Q would ask, I'm just kind of interested in your comparative series between the asleep and the awakes. One of the reasons people talk about doing them asleep is false, positives, basically, that you'll have a patient awake and maybe they develop an SMA syndrome or not moving. It's going to prevent you it doesn't look like you saw that in your series, but I know that's something kind of people talk about. But I've moved to the way you do them. I know the way Komatar and Mike do them, really doing, if I'm on the fence at all, doing it awake, doing the motor cases awake as well. It gets the team comfortable, it gets you more comfortable, and I think there's very little downside.
Yeah, I'd be interested to hear also from Miriam the positives, false positives. I mean, I'm sure it happens. I mean, the more you do, I think for me, what is important is that we move expeditiously in the case, so that way you minimize. And nowadays, what we're doing is just like with Miriam uses that little suction with the stimulation, because she's not wasting time. She's stimulating as she's suctioning, and when she finds it, as she said, she's got a high current, so that way you have over a centimeter of a spread potentially, and you're beginning to get a sense as to how close you may be getting. So there are little tools and techniques that you can use. When I was a resident, and Mike can tell you, this was a case that would take, Dr. Berger 8 hours, and I cannot possibly take that long and do it nowadays because the patients cannot tolerate it. Then you get to the point where you don't know what's happening.
Yeah.
I mean, so it's too long. You got to move.
Yeah, agreed.
Beautiful case. Beautiful case, Brad. Beautiful.
Yeah, that's a really nice resection. And it's actually lucky that it's an oligo. I'm hoping that my guy has an oligo too.
Yeah.
And I think the other nice thing about the mapping here is it helps, at least for me, decide exactly where to make the corticectomy, because it looks like this tumor doesn't come exactly to the surface. It looked like you did have to go, a centimeter or so before you get to enhancing tumor.
Correct. Until you get to the enhancing tumor, but this portion here was clearly kind of pale, like Dr. Q's case. I mean, you see it, it looked abnormal. And so my intention was to take all of this. But yes, I mean, clearly as you got down to the kind of the enhancing, which looked even more grossly abnormal. But yeah, it certainly helps with that, with your confidence in saying, hey, I want to do a big corticectomy here, and I want to make sure I'm not over something eloquent. And so that helps.
The other thing that I've had luck with, and not for malignant glioma, but for Mets that are perirolandic, is actually to do an intrasulcal dissection to get to it if it doesn't come to the surface. So, to just, basically split the, the arachnoid between the motor strip and the primary somatosensory and find the sulcus, and then go through that to get to the shortest distance to the tumor, which kind of help preserve some function. I have not done that for malignant glioma, but for other things.
Yeah, no, I love the transsulcal approach when it works and the tumor is favorable for that. I would also admit that she does continue to have some relatively mild hemisensory changes. It's not precluding her. You know, I did this case just a month ago, so it's not that long. But you know, I think when it's mild, it's not bad. I'm sure when I haven't seen one that's been really kind of devastating. I think I almost think in a case like this, there's probably not much you're going to do to make that better. And I think that may be a deficit you need to accept, or the patient needs to accept, in order to get a meaningful resection in a case like this.
Yeah, I think we have a case of that later on too. So in lieu of time, let's just keep moving along. That was a great case though, Brad. Thank you so much. Raj, you want to go next?
Hey, Mike, can I ask Dr. Q a question?
Sure, go ahead.
Q, how you doing, man? It's Rick.
¿Cómo tar?
Yep, how you doing?
I thought you'd be doing some of those push-ups where you're standing on your...
I did those already this morning. I did those
with the lead, with the lead on you.
Listen, I just wanted to ask, you know, and I guess actually Brad and also Miriam can also comment, rate of people not tolerating awakes, and what do you do? I mean, we do a ton of awakes here, and we have a dedicated neuroanesthesia team, and our rate of not tolerating awakes is probably about 5%, 1 in 20, where there's just no exam, you know, either language or motor, and you're kind of stuck with, do you biopsy? Do you just do a little tiny resection? Do you go for broke? I mean, I tend to obviously be conservative if someone has no exam, but kind of what's been your guys' experience in terms of failed awakes, and what do you do when they fail an awake?
So, yeah, so we have a failed awake. As the years went by, I got a lower number. When I look back early in 2005, when I first started, my rate could be as high as 10%. By 2010, it went down to about a 2 to 3%. Nowadays, it's more in like in the 1% category. But I tell you, it is directly correlated to my neuroanesthesia team. I haven't written about that, and luckily there's no neuroanesthesiologist here. But the more the neuroanesthesiologist is an expert, the less the hit rate that I have had over the years. But in those that I do have, like once a year, you have 1 or 2 cases where I go in and the patient cannot tolerate, I do exactly what you do. Because my intention was to give him a good resection, I couldn't, the patient's not waking up, or they put him under a little bit of propofol and suddenly he gets belligerent, and I have at least 2 patients that just rip their heads out of the pins, and they just like completely all over the place. I had to abort. You know, if I can get a biopsy, I get it, get out, and then I talk to them. Do we need to go back? You know, and sometimes, I tell you what has been going the last 4 years, anesthesiologists, what they do is they block the patient.
You're muted, Q.
And mute.
There you go.
Yeah, I'm sorry, we're getting muted for some reason. But Ricardo, what I was gonna say is that what we do is we block them before they go into the OR. So sometimes we keep them absolutely awake, zero anesthesia. I'm talking about like you and I right now, but they are completely numbed before we go. So that's what we're doing nowadays.
Yeah, that's awesome. I would say, Rick, you know, my approach is not just to do a biopsy. Honestly, if we can't wake them up, I would say that our rate is probably in the 5% range as well, where they're either too agitated or just can't tolerate it. And I usually resect a portion of the tumor that I feel is not close to eloquent areas. There's usually some portion of it that you feel that you can safely get. I'll usually get that and probably be a little bit more conservative with the stuff that I think is close to either motor or language. But I'll usually take the portion of the tumor that I think we can get to.
Yeah, it makes sense. It's also good to have MEPs as backup, so that if it's not involving language and it's just near motor and someone can't tolerate the awake, you can always put them to sleep and just do motor mapping.
Yeah, Rick, we've had the same thing, and it's probably on the order of 5%. And I would say we see it most in patients with pre-existing deficits that wake up with more severe deficits and just don't come back to baseline despite not really having any head intervention. So we will either, depending on how poor it is, if there's something monitorable, but maybe not mappable, you know, we may just have them chat with us periodically or do some basic tasks while we do it. Or do like Miriam said and try to do a limited resection. I like the idea of the motors. We've really gone to running continuous motor evokes off the grid. So from the cortical motors, we found that to be a really nice way to effectively get kind of cortical stim, as opposed to, especially when you're doing them awake, with the transcranial motors end up being stimulating far subcortical, and you end up maybe getting false information. So that's also a nice technique, like you said. But it's relatively uncommon, I think, when you have a team that does these a lot and are comfortable doing them.
All right, thanks.
I'm up.
Okay, Raj, yeah.
Hey, so thanks everyone for the opportunity. And one quick thing, and I know we're running short on time, but I'd be remiss if I didn't thank Dr. Quinones. He's been a great mentor to me over the years, and I'm eternally grateful for his
Not a
mentorship.
mentor, Raj. I've been a tormentor.
all good, all versions of the same good thing. So I do have one, I think, relatively straightforward case, but the question was, it's a case I did about a week ago. And I've been thinking about extended resection and things that I could have done to maybe I've gotten a bit more. So so the patient was 58 years old. He had no real significant past medical history, and for a few weeks he had some worsening speech issues, some expressive speech issues, and some paraphrasic errors. You know, especially I think difficulty with naming. Additionally, he had a right homonymous hemianopsia. And this was his imaging when he initially came in. So the flare is on the right and the contrast enhancement is on the left. So it sort of fits with the types of, you know, with optic radiations and generally in the speech area. We did get a functional MRI, and I'll show you a handful of those pictures here. You know, it didn't really have a lot of uptick in the tumor itself. And his SLF and AF were pushed posteriorly here, that you can see. Oops, let's see here. There was no activation or no, you know, during the functional mapping of his supramarginal gyrus, but there was in his angular gyrus, as you can see. You know, the optic tracts were fully infiltrated with tumor. I think that's the main point that we wanted to show here. And his cortical spinal tract was just anterior to some of the tumor. And again, optic radiations, and, you know, really just infiltrated with tumor. There was some spurious activation during speech, broadly speaking, but really tumor was involved in speech areas, cortical spinal tract. And what made it a little bit more complicated is from the time that he saw me, you know, within a week and a half or so, he got a functional MRI, and this is the day prior to surgery. And so I wanted to, so that did sort of change part of my plan. You know, the important part here is now that it was involving the corpus callosum, it was still quite large, and this is just for reference for supramarginal gyrus and angular gyrus. And this is just a little bit a different angle of corpus callosum, and it really goes right up to ventricle. So I thought, you know, I had some ideas on what my goals of were surgery. You know, it wasn't a awake craniotomy, but I had some ideas of what my goals would be, you know, going into it, especially given that there was some involvement of the corpus callosum, and there were, you know, I didn't show all the pictures, but there was some faint sort of contrast enhancement. Maybe if I go back on the sagittal, you know, all, you know, posterior to the tumor, there is sort of this faint contrast enhancement. So I thought it might be interesting just to get some thoughts from the group, you know, given where, you know, tumors infiltrating cortical spinal tract, et cetera, et cetera. What would your goals of surgery be in this kind of case?
Raj, it's hard to tell, but is there leptomeningeal spread of tumor? Like, is that stuff in the contralateral ventricle or along the folia of the cerebellum? Is that true enhancement?
No, it's not. It's not. I mean, there's diffuse areas of enhancement, you know, sort of punctate areas, occipital lobe, parietal lobe, but nothing over here. Nothing that's true enhancement. You know, there's little small blood vessels if you look at the next couple cuts.
So I think that from my perspective, Raj, when I look at a tumor like this is of course, it's tough. I think if I understand, there was one image that you show where I see the contrast coming all the way up to the surface. And I think the image before, it was right there, the one in the middle, you can see. So I think that is all that is tumor already. You know, I just judging from what I seen, especially in that image, of course. So I think that the patient already has deficits. In this type of situation, my biggest concern now would be to not, same as the ones before that you showed, that Brad and Miriam showed. My concern would be to leave him hemiplegic, because I think the patient already has speech difficulties. The tumor, I think, is going all the way up to the surface. I think the functional MRI, there must have been a week or two or a month distance between that and when you got this preoperative MRI or something like that. So I think that that's going to go. My second goal, of course, would be first is not leaving them with hemiplegia. Two is see if I can get and resect as much as possible. Even if the corpus callosum is involved, we now are beginning to understand that the less tumor burden you leave, the better it's going to be for the patient. But of course, you walk a fine line between that and outcomes. This one is going to be more challenging to keep him awake because of all the deficits that you mentioned to me. So this one may be the one that I go back to what Ricardo said and Brad and Miriam, where I can potentially do him asleep and concern more about the cortical spinal tracts, the motor function, rather than the speech function. The speech function, we know that mostly is laterally in the temporal lobe. I come in from a little bit more posterior potential where all that contrast enhancing is, and try to preserve his cortical spinal tracts. And this is the one where I do deep stimulation, with for the cortical spinal tracts potential. That's the way I'm thinking about this, but I'll be interested to see what Brad and Miriam think about it, and Rick and Mike.
Yeah, I completely agree with you. I think keeping him away from mapping may be challenging given his speech deficits. I think that despite that corpus callosum stuff, I think you should try to do an aggressive resection. And then, as he hopefully makes it through standard treatment, you can always come back and treat that disease in his splenium, either with lit or, something else. And I think that being aggressive up front is a way to go, because if you are not, I don't think he would make it through radiation. It's such a large volume of tumor that just through radiation, he would have so much swelling and need so many steroids that he probably wouldn't really be able to complete RT. So I think that, you're either going to resect him and give him a shot. And if you're not going to resect him and just do a biopsy, then it's really a palliative case.
Yeah, I agree with everything. I mean, obviously there's so much mass effect here. There is an increased risk of doing it awake just from the mass effect standpoint as well. And so your goal is to be safe with cortical spinal tract, but also, get as much as you can out to decompress, because otherwise he'll never get off steroids and you're going to have a whole nother set of issues.
Gotcha. Yeah, thanks everyone. So I did do it awake. This is his post-op image. Is here. I didn't get to go after that corpus callosal stuff. He was awake for about 90 minutes or so. And so I think, the vast majority of some of this stuff, is out, with some blood products in the resection cavity. But, it is, he's done well. He went home post-op day 2. But it is a guy that, I'm keeping a close eye on. He doesn't have any new deficits after surgery, which is good. It's one of those things that, getting, folks who've been doing this for a long time, getting their thoughts on, when to push an awake craniotomy and when to just, get this mass out and be aggressive, especially with this kind of stuff, is helpful.
So were you able to map out speech on that lateral superior aspect?
Yeah, he had a little bit of speech arrest once during surgery, and so that was something I was cognizant of. But I was still able to get, I thought fairly aggressive.
Great job. Yeah,
That's awesome.
Yeah.
Looks like you can teach us about pushing the boundary.
No. So I think that's all I got on this one. He did well. He's home and he's grade 4 methylated, unfortunately, and wild type, unfortunately. But, he's getting the standard treatment. So here, I'll stop sharing.
Maybe in the last 2 minutes, Dan, do you want to just show the last case, and then we'll wrap it up because it's already a little over time.
Sure. This is a very quick case. So thank you so much, Dr. Q. That was a great talk.
Thank you. Remember, I got to make it to the bar. I got the happy hour.
Okay, we'll make that happen. So this is a 31-year-old female. About a year ago, she experienced a seizure in her left leg.
Share your screen, Dan.
Sorry.
I think everyone's just looking at me for some,
Can you see it?
Yeah, I mean something. We see your name.
It's coming up. There you go.
Now?
Yeah.
We're good? Oh, okay, cool. So this is a 31-year-old female presented with a seizure involving the left leg. She noticed some left leg weakness, and especially in the foot, difficulty to balance. Seen here having this non-enhancing T2 hyperintense right parietal lobe lesion. Looking at the fMRI, looks like hand motor, sort of the anterior lateral aspect of this tumor. We're thinking this could be a low-grade glioma, cortical spinal tracts, or sort of the lateral border of the tumor as well. Intraoperatively, we found small amounts of tumor anterior that were stimulating. We used 2 to 3 milliamps, so we left a small amount of tumor at the sort of anterolateral aspects. And one point that I wanted to bring up, that Dr. Ivan and Dr. Komatar like to book these cases where the tumor is near the motor strip with neuromonitoring, looking at motor evoked potentials, really for 2 reasons. Number one is it's sort of like a backup in case the patient's exam their awake exam is not good. They're able to test for EMGs as sort of, some level of backup. And then 2, when they're anterior to the motor strip, we've actually submitted this data looking back over patients who wake up with a deficit. It's always a question, is this SMA syndrome or is this a permanent injury? And we found that in patients that have preserved motor evoked potentials but wake up with a deficit, they typically, almost 100% of our patients have recovered, versus when they lose the motor evoked potentials, they tend to not recover, and the deficit tends to be permanent, and that's about 97% of our patients have been found to show that, so it's sort of a good prognostication tool as well. So the patient did very well postoperatively, had some numbness on the left side, a little bit of weakness in the left upper extremity that improved by her 1-year follow-up visit. This was an anaplastic astrocytoma, WHO grade 3, IDH1 mutant. She got TEMDAR and radiation therapy, and was doing well with a stable scan at 1 year.
Thanks, Dan. Thanks for presenting that case. I just interested in how many people would do the right-sided kind of, tumor that's in motor sensory awake versus asleep. I think, here Rick and I really taken that stance. I think, as Dr. Q has kind of alluded to, is doing more and more awakes, right or left, awake or non in speech area or non in speech area, and just have seen better outcomes with that. And if you do that, I guess, and what Miriam was asking before is, how often can you really monitor and stimulate for sensory, and does that guide your resection at all, or does that just kind of lead you to understand what the deficits are going to be for sensory post-operatively?
I was going to say, Mike, the beautiful case that you guys did, and I 100% agree. I am doing the majority. I'm not talking about 57. I'm talking about 95% of my gliomas awake. I would have to have a very strong reason, whether dominant, non-dominant, is speech, motor, anywhere, because I do believe we are now beginning to understand that the process of anesthesia itself is already known in breast, promotes self-diffusion and propagation. And I believe that there's a role also for this shutdown of the central nervous system, decreasing your immune system, potentially for this cancer to spread out. And there's some data out there, animal data and some human data in other cancers. So I do in most of them awake. Like I said, I would have to have a very strong reason not to. The second question is, in that particular case, this sounds like a simple case. That was a very challenging case, because I can see that tumor was not coming to the surface. I can see that there's a cortical. When you opened it, you can see the one before, especially in the sagittal and the coronal right there in the middle, there was normal brain. So this is, you're going to have to know exactly where you're going to sacrifice and what you're going to preserve. And that was a beautiful case that illustrates why, to me, it's important to keep them awake and to try to resect as much as possible, because I know when I open, the whole brain is going to look normal. And that's probably what you saw. And now you have to make the adjustment. These are, to me, the most complex cases. They seem simple, but they're not, because you have to choose where you're going to go. So that's how I ended up doing. So I think that's congratulations. Beautiful case once again.
Yeah, Mike, similarly, I've kind of gone to doing almost all these awake. I'm curious what your protocol typically is for these cases in terms of doing the mapping, particularly the cortical mapping. I mean, what we've kind of adopted is typically, we do like kind of an asleep, awake, asleep paradigm, and we will oftentimes do the mapping prior to waking the patient up. to feel like we kind of get cleaner cortical maps, and it's less discomfort for the patient. And then once we've done that, then kind of really waking the patient up and moving. Curious what you guys are doing.
Yeah, I mean, we do have the patient, just on induction and pinning and opening asleep, but then they're pretty much awake for the rest of the surgery at that point in time. And the other thing that I've changed, and this is just listening to Dr. Defoe, is, I do try to lower the stimulation as much as I can at the beginning to understand, especially because you could map out motor right here very easily, to understand what in this particular patient is the lowest threshold so that you can, and then as Miriam said, I do go up at a higher level, and then as I'm going through the middle of the tumor to find those tracks. But I know that, now I know that, okay, in this case, we were able to stimulate the surface at 2 milliamps, which is really low. Sometimes you can only do 3 or 4, but in her it was 2 milliamps consistently. So I knew that, at the 3 I could probably go down to 3 milliamps on the subcortical dissection and really know that that's the boundary for her. But it's not I found it's not the same for all patients. Some patients, you have to go all the way up to 4, even when you're right on motor, to get that positive stimulation when they're awake. And that's important information while you're going through the tumor trying to find the tracks.
Yeah, we do something similar to what Mike described, which is kind of asleep and then awake, and we do the map. I typically do the mapping during the awake portion. In my hands, it's just been a little bit more reliable, and then like to keep them awake through the resection and even through the closure as long as they're tolerating it. I think that this was a beautiful job that you guys did, and I agree with Q that sometimes these cases can be challenging. And Mike, from my standpoint, I agree with you. I think that from a somatosensory standpoint, usually it's just a deficit that I feel like we have to kind of accept. Like, we're less willing to do it with motor or language. For somatosensory, we tend to be a little bit more liberal with that and saying, okay, well, this is going to happen, and we just need to get the best resection we can to try to improve survival. And the one time that I regretted that was in a patient who had a pretty bad proprioceptive deficit that basically was equivalent functionally to being plegic, and that they had full strength, but they couldn't really use that arm or leg. And so I kind of regretted that decision. And so that's a little bit what I'm worried about in the patient that I just showed you guys today.
Great. Well, we're definitely over time, so thank you so much for giving up your Wednesday night. Dr. Q, thank you for the fantastic talk, and to all the panelists again. We look forward to having you on again sometime soon. In the meantime, everybody stay safe and take care.
Yeah, thanks
Thank
everyone.
you guys. It was great seeing all of you.
Adios.
Have a wonderful
Bye-bye.
evening. Bye-bye.